Good morning, everybody. Welcome to the May Survivorship Lecture Series. Today, I'm very excited to introduce Dr. Andrew McLeod, who is a commonly mispronounced name. He works for the Cancer Prevention and Control Unit of the University of Illinois Cancer Center, and works in the Institute of Public Health and Policy. But he's a nutrition scientist and registered dietitian by training, whose main research interest lies in how diet is related to cognitive health through the gut microbiome. He is particularly interested in the interplay between a Mediterranean diet, cognitive processes, and disease populations and microbial metabolites. He is currently exploring those complex relationships as a postdoc research associate at UIC under Marion Fitzgibbon's department. He's investigating the gut microbial and dietary origins of cancer-related cognitive impairment. We are all very excited to hear your talk this morning. Go ahead, Dr. McLeod.
Thank you for inviting me for the kind introduction. So I'm going to share my screen. It looks like I have that capability. Oh. All right. So hello, everyone. Thanks for coming. Um, my name is Andrew McLeod, and like Deborah said, I'm a postdoc here at UIC, and I'm going to talk about um, this project, and it's funded by a K99 grant that Marion mentioned, and I have several co-investigators. These are essentially my mentors and advisors on the K99 grant. It's a training grant, hence mentors and advisors. Marion Fitzgibbon is my main mentor, and then Kent Hoskins and Krista Verity are my co-mentors, and I have four advisors: Dr. Chin, Bernabe, Patil, and Wafel. Patil was at UIC. She's at University of Michigan, and Jeff Wafel is at MD Anderson in Houston. So I will describe their roles and my training near the end of the talk. But before I get into the research I've done thus far in the grant, I'd just like to explain what is entailed in the K99 for those that are unfamiliar. There's dozens of these types of grants, so let me explain it a little bit. There we go. So a K99 is a 1 to 2 year postdoc career development / training grant from the NIH. It covers $30,000 a year in training costs, such as for tuition for classes and workshops, and included in the $30,000 a year is our research costs. And then after the K99 is finished, in the ROO phase, $249,000 per year is provided for 1 to 3 years. That's the NCI's pay for completing a larger research project that is based off of the research and training conducted in the K99. The major caveat is that the ROO funds are only made available if the trainee, i.e. me, secures a research-focused tenure track faculty position by the end of the K99, and no cost extension for a year is allowed. So with that out of the way, let's go to the fun stuff. So I'll just provide an outline here. We'll first talk about what is cancer-related cognitive impairment, which I'll just call CRCI for now. For the talk, we'll talk about the current statistics of CRCI and diets that may play a role in CRCI, and then the nuts and bolts and progress of my K99. And I should say I'm a year and 9 months or so into the K99, so only 3 months left. So what is CRCI? It's simply put, it's among cancer survivors, a reduction in cognitive performance in any one of several cognitive domains, such as executive function, memory, processing speed, and this is relative to cancer-free controls. So a little bit about these cognitive domains. So executive function involves many mental processes such as planning, working memory, mental flexibility. So for example, working memory, it's the ability to remember a set of things while mentally manipulating a number of different sets of things. So for instance, you could tell someone seven random numbers and ask them to repeat them back to you in order from lowest to highest. So not only does the person have to remember those seven numbers, they also have to numerically order them at the same time. So it's kind of two different processes at the same time. It's a working memory task. Um, and then the third bullet, CRCI can occur before treatment even starts. So after diagnosis, before any treatment. During treatment, that's when it usually occurs, if it does, and then sometimes it comes about after treatment. And that's after primary treatment, surgery, chemotherapy, or radiation. And so once you measure these cognitive processes in cancer survivors, how do you determine if they have CRCI? So there's a common definition, according to some international standards that have been proposed, which is that if a patient scores 1.5 standard deviations below a mean on two tests, or two standard deviations below the mean on one test, then they're considered to have CRCI. And the mean and standard deviations I'm talking about come from, can be a control group that age and like age matched, education matched controls, or it can be from a larger population. Psychologists have, they kind of know what the normal score is, the average score is for a non-disease population for various tests. And so you can compare what the patient gets on what scores they get on these cognitive tests. You can compare it against population means and standard deviations to determine if they have CRCI. So what are some of the prevalence statistics on CRCI? Well, most of the data we have comes from breast cancer survivors. Most of the experiments and studies have been done in those type of survivors. And it's been found that up to 35%, so over a third of breast cancer survivors may experience cognitive impairment, and this can be as much as 10 years after treatment. So it's a devastating, long-lasting condition at times. And many experience it before, during, and after treatment, but for some it persists. And the number of breast cancer survivors is expected to increase by 1 million by 2030. And some of the issues with CRCI is that it degrades quality of life. Compared to breast cancer survivors without CRCI, those with it have increased stress, increased rates of anxiety, higher rates of depression, and PTSD. And no risk factor has been definitively identified, at least no modifiable risk factor. Age is considered a non-modifiable risk factor. And there are a few established treatment options. So one potentially protective factor that's yet to be explored is diet. So that's where I come in. So let's talk a little bit about diet and cognition in breast cancer survivors, which is the population that I'm studying currently at UIC. So there's been a few studies looking at diet and cognition during treatment. So not very recently, but somewhat recently, there was a feeding trial where they provided metastatic breast cancer survivors with 8 weeks of plant-based foods, and they measured at the beginning and the end of the intervention subjective or patient perceived cognitive performance and issues. And what they found was that in the diet group, there was, compared to the control group, there was a randomized control trial. The diet group had less problems remembering things, less problems concentrating, and less problems multitasking. Um, and then within the diet group, there was a reduction in perceived cognitive impairment and an increase in perceived cognitive functioning, but those latter two metrics were not different, statistically speaking, between diet and the control group. So somewhat of a signal there that diet is related to cognitive processes during treatment. This was metastatic breast cancer survivors, so they go through a lot of chemotherapy. So this isn't exactly the population I'm studying, which is stage 1 to 3. I'll get into that soon. And another study, this was done with this observational longitudinal study done in over 1,000 patients with breast cancer who were post-treatment. They found that vegetable intake, fish oil supplementation, and tea drinking was associated with improvements in objective cognition. So, meaning pen and paper or cognitive that cognition processes that are measured with pen and paper, not patient reported. And they particularly they found an improvement in verbal fluency, so their ability to recall words and to say words quickly. And that improvement occurred 18 months to 36 months post-treatment. So the more vegetable intake, the more fish oils a survivor consumed 1.5 to 3 years post-treatment, the better their cognitive performance, at least with verbal fluency. So another signal that diet could have a role in cognitive processes during breast cancer survivorship. And so those were post-treatment. No one's really looked at these processes during treatment, which is what I'm doing. And so this is a somewhat complicated graph, so I'll walk you through it. So the question is how, or at least the question I have is how can diet, or how is it related to cognition? Well, my hypothesis is that it's partially mediated by the gut microbiome, which are the collection of bacteria in our guts. And here's a diagram conceptualizing the research thus far, at least from the literature. So we'll start on the left with a Mediterranean diet. It's been the focus of my work so far in my research career. So research has shown that a Mediterranean diet is associated with a particular bacterium called Faecalibacterium prausnitzii. It's a probiotic. And Mediterranean diet consumption is also associated with a particular metabolite that the gut microbes produce called polyamines. And this is in non-disease populations, but in a study in breast cancer survivors, they found that this very bacterium and these very same metabolites are associated with neurological health in breast cancer survivors that have gone through chemotherapy. So there's potential then that a Mediterranean diet is influencing this bacterium and these metabolites to impact cognition in breast cancer survivors. And moreover, this bacterium F. prausnitzii, it produces butyrate, which is a short-chain fatty acid that they produce from undigested fibers that we eat. And this metabolite, butyrate, is correlated with reduced peripheral inflammation, which is a potential driver of CRCI. And then lastly, a Mediterranean diet can reduce the concentration of LBP, or lipopolysaccharide binding protein. And this is a measure or a proxy of the translocation or the movement of bacterial toxins across the gut barrier, which then could impact cognition. And there's some evidence for this in that some of our preliminary data has shown that LBP is higher in those cancer-free population, but in those with mild cognitive impairment, which is sometimes considered a precursor to Alzheimer's. And essentially, chemotherapy counteracts all of these, at least I hypothesize that it counteracts all of these beneficial relationships that I just talked about. So firstly, chemotherapy itself can reduce Faecalibacterium prausnitzii levels. It's also associated with reductions in dietary intake of Mediterranean diet components, particularly fruit. And also chemotherapy itself can increase LBP. So I hypothesized that a Mediterranean diet adherence will be related to higher objective cognitive scores during chemotherapy, and that um, the gut microbiome will mediate that relationship. So to test those hypotheses, my K99 ROO has three aims. The first aim is simply an observational longitudinal study where we measure diet, gut microbiome diversity and composition and cognitive function in 30 breast cancer survivors right before they start chemotherapy and halfway through chemotherapy, and then around the time chemotherapy ends. And after that, following that, there's the second aim, which is still part of the K99. And I've done a lot of work on this already, which is to develop a Mediterranean diet feeding trial or study for breast cancer survivors via two phases. So the first phase is to would be surveying and interviewing breast cancer survivors on their experiences with eating during chemotherapy and their opinions of a Mediterranean diet. And that will inform recipe development for the feeding trial. And then in phase two, I will use their feedback and the interviews and surveys to do a mini feeding study where we create tailored Mediterranean diet meals that will be provided for 2 weeks um, to five breast cancer survivors that are undergoing or going through chemotherapy. And we're going to get their feedback of the recipes of the meals we give them to optimize those meals. For the aim three of my study in the ROO phase, when I'm a tenure track faculty, to conduct a 12-week Mediterranean diet pilot feeding trial among 30 breast cancer survivors undergoing chemotherapy. And the point of that is to see if we can curtail cognitive impairment or at least see less cognitive impairment in those receiving Mediterranean diet foods versus those who do not. So for aim one, like I said, it's an observational longitudinal study. We're going to measure the gut microbiome beginning, middle, and end. That's through it's disgusting, but through their stool. It's the easiest way to measure it. And then we'll also measure cognition with pen and paper tests only at the beginning and the end of treatment, not at the middle, because 3 times within a 12 to 24 week span would introduce practice effects where they would get so good at the test at the end, there would be very little variability at the end, and it would be harder to do statistical testing and generalization. So, and then a little bit more about the measures that we're conducting in aim one, and this is at each time point. So there's 4 categories I've created. First one being diet. We'll measure their diet beginning, middle, and end with 2 dietary 24-hour recalls at each time point. A 24-hour recall is simply asking what a participant ate in the preceding 24 hours. And we'll do that before an infusion and then after an infusion. And then from these diet recalls, we'll derive a 55-point Mediterranean diet adherence score. And then regarding the gut microbiome, we'll measure through the stool fecal microbiome diversity and composition, F. prausnitzii abundance. We'll also measure in the serum polyamines, butyrate, and LBP. And then cognition measurements will capture learning, memory, processing speed, and executive function, again, just at the beginning and the end of chemotherapy. And then finally, we're going to measure a whole host of covariates. Here I list just some of them, not all of them. We'll take a look at stool consistency, which is a variable highly correlated with gut microbial composition. We will measure moderators of cognition, such as physical activity level, medicines, depressive symptoms, fatigue, worry, and then also measuring a potential mechanism of CRCI, which is peripheral inflammation. That'll be done through C-reactive protein. And then we'll measure cancer characteristics, treatment regimen, demographics, and many others. Eligibility criteria, so you get a sense of who I've recruited. Pretty broad study in terms of inclusion criteria, age 18 to 99, male or female. We haven't done any males yet. English speaking, stage 1 to 3 breast cancer, scheduled to receive chemotherapy. Some of the exclusion criteria include significant cognitive disorders like dementia, prior cancer, except non-melanoma skin cancer, and prior receipt of cancer treatment. So a little bit about the progress for AIM-1, which is an observational study conducted throughout chemotherapy. And we've recruited 22 of 30 participants over the past year, so making really good progress. 16 of these 22 that have been recruited have finished data collection. And then I've recruited the help of 2 volunteer research assistants, primarily to help with the dietary data collection because there's so many recalls we're conducting. And then some of the demographics based off the 22 participants that I've recruited. Data collection is still ongoing, but the demographics here should be representative of the entire sample once I'm finished recruiting. We have a middle-aged group on average, about 48 years of age, the range being as young as 32 up to 66. And we have a high proportion of African-American adults at 64%, and 32% identify as Hispanic. As I said, we measured a slew of covariates. Here's just a snippet of them. So the graph on the left is a scatter plot of CESD scores, which is a measure of depressive symptoms. And that survey identifies individuals at risk for clinical depression. And the cutoff is 16 or greater to be classified as potentially having clinical depression. And it's hard to tell from this graph here, but 45% of our sample are at risk or were at risk for clinical depression, based on the fact that 45% had 16 or score of higher on the CESD. And then the graph on the right is representative of one of the questions on the God and Leisure Time questionnaire, which asks about physical activity levels during a typical week. And the question this bar graph on the left or on the right represents is how many times on average does the participant engage in strenuous activity for 15 minutes or more during their free time. And the strenuous activity includes soccer, swimming, bicycling, and most were not engaging in that type of physical activity. On the left, or because 0, there's 19 people that said that they do not do that. And this is all at baseline. And now let's move on to the second aim, which is developing a med-diet feeding study. It consists of 2 phases. As I said, the first phase is conducting surveys and semi-structured interviews among 20 breast cancer survivors who have recently completed chemotherapy or completed it within the last year. And with the survey, we're trying to understand the impact of treatment on food preferences. We're assessing preferred frequency and timing of meals, as well as preferred food preparation characteristics, such as temperature, consistency, spice level, etc., during chemotherapy. And this information will help us create tailored recipes. And semi-structured interviews are also part of phase 1. And in those interviews, which last about 30 to 45 minutes, we ask questions to assess the feasibility and acceptability of a Mediterranean diet feeding trial, and also just to optimize it, improve it. We ask questions in these interviews related to diet and taste changes during chemotherapy, their knowledge and perceptions of a Mediterranean diet, how they would potentially change a Mediterranean diet to suit their preferences if they were to have consumed it during chemotherapy, and any of the possible positives and negatives to being in a feeding trial during receipt of chemotherapy. So progress on AIM-2 phase 1, which is surveys and interviews. We've finished data collection, did that last month, and I received a tremendous amount of help from with conducting the interviews and doing the coding of over half the interviews from Amanda Seguin. She's a dietitian and master's student at UIC's MPH program. I taught her how to conduct interviews, how to clean and code transcripts, and I learned all that from Crystal Patil. And she presented some of our results at U.S. Cancer Center's Gary Crew Research Symposium. And I'll present some of those results at the American Society for Nutrition Conference coming up in July. And here are some of the results from the surveys and interviews. So on the left are some of the demographics. So again, a middle-aged cohort, large representation of African American adults. And on the right, I just put 3 of the results from the surveys that we conducted. And we found, among many other things, we found that a third of respondents preferred breakfast over other meals like lunch, dinner, and then a quarter indicated lunch as their favorite meal. And the most popular type of food among different types of foods like salty, creamy, soft, sour, crunchy was soft food. So 55% of respondents reported that they like to consume soft food during chemotherapy. So we've incorporated that into the recipes that we've created at UIC. I'll get into that later. And the surveys also asked about nutrition-related side effects during chemotherapy. And again, these were among 20 breast cancer survivors that had finished chemotherapy, but we just, since it's been only a year or less, we assumed that they kind of remembered. The most common side effect was fatigue, and this is a representative of the number of people that reported these symptoms or side effects. So 18 out of 20 reported fatigue. That's not surprising. And coming in second was taste changes. You see that in the middle. 3/4 of participants reported that. And then, interestingly, almost half of the participants said that these side effects did not disturb their eating or drinking. So now moving on to the results of the semi-structured interviews. Again, the purpose of the interviews was to assess feasibility and acceptability of a Mediterranean diet feeding trial during chemotherapy. And here are the questions we asked them. The first one was thinking about your eating during chemotherapy. In what ways was it different than from before diagnosis? This gives an idea of what kind of foods they're eating, and so that we can incorporate that into the recipes that we generate. And then what is our understanding of a Mediterranean diet? During treatment, which aspects of a Mediterranean diet would have been unappealing or appealing to you from a taste and cultural perspective? And then given that X, Y, and Z would not have been appealing, how could you have modified the Mediterranean diet to make it more appealing? And what are some of the positives and negatives to being in a feeding trial during chemotherapy? And then here are some of the preliminary themes out of the 12 transcripts coded thus far. Thankfully and fortunately, most participants said that they would be okay consuming a Mediterranean diet during chemotherapy. But raw fruits and vegetables and acidic foods, which are part of a Mediterranean diet, were difficult to consume due to mouth sensitivity. Many ate smoothies that incorporated raw mid-diet foods, and we're going to include seasonings that are more acidic on the side when we provide meals to participants, just in case some participants have mouth sensitivity and they can't tolerate the acidity. And greasy foods were intolerable for many, thus reducing olive oil in the recipes will likely be necessary. And then one of the feeding trial con was that they think could happen is that the participants simply wouldn't like the food due to allergies, the fact that some of the food needs to be reheated, potentially in a microwave, and then a lot of participants unsure if they would like the new foods that a Mediterranean diet would introduce into their diet. And then we're starting a phase 2 of the feeding study, and that's to conduct a 2-week miniature med diet feeding study in 5 breast cancer survivors undergoing chemotherapy to further refine the recipes and meals for eventually in the RO phase, a 12-week feeding trial. So this trial that study we're doing right now is only 2 weeks. And the eligibility criteria is the same as AIM-1. With the feedback from the surveys and interviews, Toy Johnson, who I'll talk about later, created 7 breakfasts, 7 savory snacks, and 7 sweet snacks from the feedback we got from the interviews and surveys. and they'll eat one of those per day. Um, so that's 7 days worth of breakfast and snacks. And then for lunches and dinners, we're actually not going to be creating those just to improve the feasibility of doing this in the long run with a larger population of survivors. So we're actually going to be getting lunches and dinners from two different meal delivery services. We're going to test each one to see which one the participants like better. We'll test Sunbasket in week one. We're actually some participants are getting their food today from Sunbasket, and they're going to rate those with surveys I provided them. And RedCap, they can do on their phone. And then in the second week, we'll test Cook Unity. So these are two pretty popular meal delivery service companies that offer Mediterranean diet inspired meals. And seven all of these meals will be and the snacks will be delivered to participants' homes each of the 2 weeks. And we're going to get participant feedback for all the meals and snacks. We're going to assess acceptability, taste, texture, etc. And we'll have 2 rounds of feedback with time in between to revamp the recipes. So we'll do 1 week of recipes and the meal delivery service, and then get feedback from those, incorporate anything that they say that wasn't good about the recipes to improve the recipes, to improve the meals, and then we'll test the second commercial delivery service being Cook Unity. And then the commercial company with the highest rated food will be chosen for the AIM-3, which is the 12-week feeding trial. And then we're also going to do a brief 15-minute exit interview with each of the 5 participants. We're going to ask about advantages and disadvantages of receiving pre-made food, and then also probing for family members' perceptions. So the progress we made thus far on this 2-week feeding study is that we've developed the recipes. Toy and I have tested them, tasted them, tested the cold chain to make sure that they're delivered safely to participants. And Toy Johnson, she's a dietetic student here at UIC, and she has 15 years of culinary experience. She developed 21 recipes, which is quite a lot, 14 snacks and 7 breakfasts. And we used Metabolic Kitchen here at USC, a great resource, beautiful kitchen. And then she developed the recipes, like I said. And here are just picture here 5 of the 21 recipes she made, and this is how they're packaged. I know it's not very doesn't look that great, but we have smooth egg muffins. That's one of the breakfasts. One of the savory snacks is a soft baked falafel with tzatziki sauce. Sweet snack is a berry smoothie bowl. And then for breakfast, one of the breakfasts is a banana oatmeal. And then one of the savory snacks is a silky red lentil and turmeric soup. And they will also receive these foods as well. So they're getting a lot of food. And you'll notice that there's 2 pear brulees on the left and 2 shakshukas on the right. These pictures were taken in the early rounds of recipe development. So we have since found new recipes to replace those duplicates. And as you can tell, a lot of these are soft foods. So we chose to do that to make a more all-inclusive approach to these recipes. It's kind of difficult to tailor make meals for each participant. That would require a personal chef, and we just don't have the resources for that. But we chose recipes that were naturally included soft foods like soups, dips, puddings, muffins. And that's to accommodate the fact most respondents and interviewees preferred softer foods. And we also chose to make smaller portions, and most survivors need to eat smaller portions more frequently to avoid stomach upset and other gastrointestinal symptoms like nausea. And to complete all of this research and to do all the training, I gathered a mentoring team of experts. So at the top of the screen, it's Dr. Marion Fitzgibbon, a behavioral scientist. She's my main mentor. She's providing guidance and conducting dietary interventions in high-risk individuals and providing a plethora of career development wisdom and opportunities. Dr. Krista Verity, pictured on the left, she's a nutrition scientist and is guiding me in conducting the 2-week feeding study. And Dr. Kent Hoskins on the right is, bottom right, is providing training and conducting research in breast cancer survivors undergoing treatment. These 3 individuals have been a tremendous resource for me. Couldn't have done the research I've done without them. I also have a group of advisors to help with other aspects of the studies. So on the left, first is Dr. Jeffrey Wafel. He's a neuropsychologist specializing in CRCI. He's at MD Anderson in Houston. He's providing training, and conducting and analyzing objective cognitive evaluations in breast cancer survivors. So he's basically telling me, how do I handle all of the data that is generated from the cognitive tests? And Dr. Bernabe is a system biologist and gut microbiome expert. And Dr. Chen is a biostatistician with the Cancer Center. They're in tandem, they'll provide training and advanced analysis of complex multivariable data sets, which is represented by the gut microbiome data and the dietary data. There is a lot of variables, a lot of missing data, a lot of variability. And Dr. Crystal Patil is an expert in qualitative data collection. She used to be the dean in the School of Nursing here at USC. She moved to the University of Michigan a couple of years ago, and she's been providing training to me and conducting and analyzing the interviews and surveys. And then hopefully, if all goes according to plan, in the ROO phase, I will conduct a pilot feeding trial that will randomize 15 participants to a Mediterranean diet arm and 15 participants to a usual care arm. And the med diet arm, those in that arm will be provided all of their meals for 12 weeks. And these will be meals that were optimized in the K99 phase. The usual care arm will receive the care they usually would from the providers, will also provide the same level of contact between both arms to account for the fact that simply interacting socially with the researchers can have a cognitive benefit, and we don't want to see differences in the arms based on that. And if the pilot feeding trial is feasible and successful, we'll apply eventually for an RO1 to fund a larger feeding trial with even more participants. And with that, I believe that's it. So I'd be happy to take any questions. I know I finished a little early. Thank you for listening so far.
Yeah, thank you, Andrew, for giving us an insight into the design of a trial like this,
Mm-hmm.
and all the factors you have to consider. It's really intricate, the type of research you're doing and the planning that needs to go into it. And we'll definitely invite you back once you get some more results.
Definitely. That'd be fun.
Yeah, definitely. We are all excited to hear what the outcomes are. I mean, we all kind of have a feeling, right? Like we
Yeah.
feel that this diet and everything will help cancer survivors, and at least previous literature and the mounted evidence so far. But this is really nicely pinpointing and, figuring out that one relationship and bringing in that gut microbiome, which is so important. So I'm glad you've incorporated that into your research. And the thing that struck me the most about your talk, too, is the incorporation of thinking about survivors and their needs, too, right? That's why
Mm-hmm.
you're doing all this planning, doing the soft foods, having so many meals, which meal is preferred. It's really fantastic to have that attention to detail. It is really what we like to focus on, emphasize in the Cancer Center at UIC.
Thank you. Yeah.
Yeah.
Yeah,
So
there's a lot of
anyone,
planning.
oh, sorry, go ahead.
I was saying, yeah, I agree with you. There's a lot of planning involved. You know, uh, someone's not gonna eats a healthful food if it doesn't taste good, if they don't want it, if it doesn't suit their preferences. So that
Right.
was the major impetus for trying to do these surveys and interviews to really understand as best as I could what type of foods they would tolerate and would like.
Yeah.
So
Yeah,
happy
exactly. If
we found
only
that.
we all had personal chefs. But yeah, I know I would love it and need to eat more vegetables. Um, so anyone have comments? Do you want to stop sharing,
Oh,
Andrew? We
sure.
could have more of a discussion. Marion, did you have anything you want to comment on Andrew's presentation? And
Well, I have said to Andrew that I think that the methodology that he's put in place is beautiful, and it's the level of detail in working with the dietitian and getting feedback from patients is something that I think what we'd like to see is this, we're going to look at the outcomes, but is something like this scalable? Because this is something that if we see that should be available to
great.
patients, and can we package it? So I've suggested that whether it be at Society of Behavioral Medicine or ASPO next year, that he put together some kind of a workshop where he's
Mhm.
talking to other practitioners and other researchers who might want to do this type of thing at their own institution.
Absolutely. And different cancer types and everything too,
Right.
right?
Mhm.
Applying it broadly to their patient base because, yeah.
Yeah,
Uh,
and the level of detail that has gone into the
yeah.
method that he's put together I don't think Andrew necessarily takes enough credit for doing that. And I think he's got to
Uh,
get that into the literature in terms of a hands-on study paper.
Andrew's a modest guy.
Yeah, very modest.
yeah, I'm so like into the research that I can't like take a step back and just really, take a
Right.
high view of it yet. Once I'm done with data collection, I think I'll be able to step away from that. But
Yeah.
you're right.
Yeah. I mean, the question from the audience in the chat so far is could you share the recipes?
Oh,
Um, so
yeah,
yeah, so
yes.
send that to me
I
and I can broadcast that out to everyone who's been invited to
okay.
this session. That would be a great thing to share because people
Yeah.
are interested in,
We'll also be
cancer
providing those.
survivors. It'll help me.
Sure. Yeah, let me write that down. So you want me to send it to you, Debbie, and you
Yeah,
can
you can go ahead and send it to me and then I'll send it out. I send out the recording and slides
yeah,
and all
okay.
that with an update, hopefully in the next couple of weeks once it gets posted.
Okay.
Anyone else have a question or comment for Dr. McLeod? Feel free to speak up. Turn off your mute. No, I mean, again, Andrew, great presentation. And, the rationale is just so well laid out.
Yeah, yeah. I thank you for that. Um, yeah, it took a lot of planning, like I said, and this is like just like the surface of it. There's so much other things that we've had to do to make
Right.
this research a success, at
Yeah.
least recruitment is just a lot of
Right.
processes and levels of
Yeah.
uh, yeah,
It's
IRB,
tough.
Cancer Center, Encore, yeah,
I mean, if there's anything we can
districts.
do, to help
Mhm.
you, let us know with survivorship and cancer risk. Um, Dr. Ganshaw was here briefly. She got pulled into a grant meeting, of course, so it's grant season. And but she said, love this project, so important. So she was sad she couldn't stay, but she will watch the recording later.
One
So
thing I wanted to say, maybe others can give their feedback, but I've learned like from a personal perspective, I've learned a lot,
yeah,
so much from just working with breast cancer survivors, going through chemotherapy. Like they're heroes. They just um they have so much going on in their life. They're still like willing to be in research, and all of them are just incredibly nice despite everything. So I didn't really have that appreciation until I started doing research. So that's really helped, I think, give a personal motivation to do the research. which I think is important to have. So
Yeah, that's really great. That's a great experience. Um, Again, if anyone has any comments or questions, a lot of folks just really love this talk. And again, once you have some data and some results, we would love to hear it. Um, so great. Well, I guess we'll go ahead and just end a little early. That's totally okay too. Um, Thank you everyone for attending today, this well-attended lecture series. Um, and next month we will actually feature Dr. Scott Capozza talking more about a survivorship program incorporating diet, nutritionist, and everything into their clinic. So a little bit of an extension of the talk, so we can keep this discussion of the research. They have some echo initiatives and keep the talks going about lifestyle. So thank you, Dr. McLeod, and
you're
everyone.
welcome.
Have a
Thank you,
great,
everyone.
great day, great
Thanks so
weekend.
much.